Welcome to Time to Talk Science and Medicine. This podcast is brought to you by the Translational Institute of Medicine at Queen's University, Kingston, Ontario. My name's Dr. Charlie Highmarch, and I'm an assistant professor and researcher at Queen's.
And my name is Dr. Stephen Archer, and I'm a cardiologist and clinician scientist, and I'm also the director of the Translational Institute of Medicine, or TIME, as it's affectionately known here at Queen's.
In this series, we're fortunate to talk science and medicine with some of the most accomplished translational researchers from Queen's University and beyond. We want to know what their dangerous idea is, which is a concept that they're working on that, if true, would change the direction of research or society. We also want to find out about the person behind their discoveries. In previous podcasts, we've sat down with clinicians and basic scientists from Queen's and beyond to discuss a diverse range of research, including cancer, cardiovascular disease, bleeding disorders, and animal care.
Today, we're very lucky to have Dr. Jane Philpott here, who's actually in her last week as the Dean of QHS here at Queen's and the CEO of SEAMO. So she's about to depart for an important role in the Ontario government tackling a problem that impacts us all, namely the provision of primary health care. Dr. Philpott is the author of a best-selling book entitled Health for All, which I've read, duly postmarked and with all kinds of questions for you, Jane, which you can find at all good bookshops. Dr. Philpott, thank you very much for coming into the podcast today. But before we get too deep into your book and your work here as Dean, I'd like to ask you to just tell us about your origin story. How did you get to be a physician and an academic, and give us your backstory?
Thank you. Well, first of all, I want to say how pleased I am to be invited to be part of your podcast and an amazing series that you've launched, and look forward to following it along the way. My origin story is that I came from small town, southwestern Ontario, in what I would consider a relatively sheltered upbringing, and found my way to medical school because I love science and I love people, and medicine is one of the best ways that you can put science and people together. And at medical school had my eyes opened not only to the biosciences, but also to the world. I had classmates in my medical school class who had grown up in other places around the world, and this fascinated me to understand the medicine and health from a global perspective. So I started to take the opportunity to travel and did an elective in Kenya in my last year of medical school, which really opened my eyes again to the inequities that exist in what people can access in the way of healthcare and their health outcomes. And that really led me onto a journey of trying to understand not just the science of medicine, but the social science, and to understand all of the things that it takes for people to be healthy. I ended up spending a decade of my career living and working in West Africa. And from there, it kind of went on to try to say, how can I not only help people be healthy at the individual level, but how can I pull back and think about the social structures that impact our health, which has led me to all sorts of interesting places.
So that raises two interesting questions. First is, I didn't know you'd been to Kenya because I read in your book about your time in Niger, but so where were you in Kenya, in Nairobi?
No, actually, worked in a little hospital in the Cherangani Hills near, some people know where Eldoret is in Western Kenya. It's famous because all of the champion marathon runners come from those hills. But there was a little hospital there, had two British surgeons that essentially were the main medical staff of that hospital. And I spent a few months with them and learned all kinds of amazing things.
Yeah, I worked at, I was sent out by Queen's I think it was in third year medicine. I went to Kenyatta National Hospital in Nairobi and worked there. And the only thing I learned was I was completely useless. It was a very informative experience, which put me in my place because I was walking around these wards of incredibly sick children and had nothing to offer them. Of course, I was a medical student, so I didn't know a lot at the time, but those are complicated patients. The other thing you mentioned that interests me, and it was in your book as well, was this issue about science, that you love science, but became persuaded during the course of your career as a family physician about the social determinants of health. And now you're dean of a major medical school. What is the role of science? I know the social determinants of health are important, but what is your philosophy on the role of science? Is that something you're still as passionate about?
Absolutely. I mean, it's been fascinating to be here at Queen's University, embedded in the science of health sciences, and to realize that, we know a lot. As you said, we're constantly learning about what it is that makes people sick and makes them well. And yet for every solution we have, there are 10 more questions. And so it's been amazing to be embedded in the incredible milieu here, where organizations like Time are saying, well, we understand this much about this particular condition, but actually we have so many more questions, and we need to establish a rigorous scientific process to be able to test our potential theories. So that's one of the reasons why I've really been glad to have this time at Queen's, to really see the breadth of what science is, and all of what are called the pillars of science have to act together.
And I'll also use this as an opportunity to say thank you, because I think you're our most frequent visitor over to the Queen's Cardiopulmonary Unit, and also, as Dean, put money at a time of budget constraint into the funding of Time, which had always just been funded by the Department of Medicine. So we really appreciate your support by the fact you showed up, and B, that you actually invested in it. So we'll try to do a good job with the investment.
Absolutely. And I was going to follow on. So the idea that there's an interface between medicine and science, it's nice to see developed. We've recently spoken to Nobel Prize laureate Art MacDonald from Queen's University, who made a strong case for evidence-based decisions being critical for pushing society forward. And of course, what we notice here is kind of medicine is often taught in isolation of science and research, but really the interface is more important than I think we previously realized.
There's no question about that medicine is not a practice or a program that can stand still, because on a daily basis, as people are interacting on the front lines of medicine and healthcare, they recognize that we don't have all the answers yet, and we can't pull those out of our imaginations alone. We have to actually test those in a rigorous way, and that's where the interface between medicine and science must continue.
Yeah, I think in your book, and we'll obviously get into the matters of primary care shortly, but in your book, you cite a study that was performed in the UK that actually looked at the cost benefits of providing appropriate patient-centric primary care, and how actually that was better for the economy all around. And obviously that's a great example, and we need more studies like that. I'm sure you'll agree.
Absolutely. And I'm happy here at Queen's, just to continue to promote Queen's, that we have also another great institute called the Health Services Policy Research Institute that does this kind of science on health services and primary health care, trying to ensure that, we do get the answers to where those investments need to happen. And you're quite right in the book. I tried to, as often as possible in a book that was intended to be, quite accessible to the general public, you have to let people know that the kind of ideas that you're sharing have their basis in science, that they've been studied.
People have thought carefully about the questions and tested those questions properly.
Exactly.
Yeah. So on this show, we tend to ask researchers about their dangerous idea. And usually it's like, how will your hypothesis, if it's true, how will that actually change the face of research? And I guess with you, we're going to modify that question and say, what is your dangerous idea that has come out of your book, and what do you hope to take forward into your new role?
Well, thank you very much for asking. And, it's funny thinking of it as a dangerous idea, and that's a great provocative way to frame it. But the idea that I put forward in the book, and it is based on science, is the concept that primary healthcare needs to undergird our entire health system, and that, in fact, we need to get to a world in Canada where every single person is attached to primary care. That means that they have a family doctor or they have a primary care nurse practitioner working in a publicly funded team, and that they can access that person in a timely way and then be integrated into the rest of the healthcare system. Unfortunately, we never built that system here in Canada, even though there are countries around the world that have done so. So my dangerous idea is we need to get to 100% attachment to primary care, and I believe it's possible.
It is very interesting, because it does sound like a great world. As a cardiologist, I would love to live in a world where I wasn't going to clinic knowing that a third of my patients had no one else other than me looking after them, or some other specialist. So I think it's a goal we all share. But one of the things that you mentioned to me privately, and then I see it in your book as well, that is very concerning about solutioning this problem is the fact that only 15 or 20% of people that train as family physicians go into full-time family practice. And you speculate on a few of the reasons why this might be, but maybe you could just talk about that, because as someone who fully supports your agenda, it does raise the question: how will we ever fill the bathtub if all the material is leaking out? All the family doctors are doing something else.
Well, it is a huge challenge in terms of reaching this goal of 100% attachment. Is that, you both know that healthcare is nothing without the people behind it. And we are going to have a significant pipeline problem, if you can use that kind of crass language, in that, we can't just open up primary care clinics across the province or the country. They have to be staffed by family doctors and the entire spectrum of the healthcare team. And you're also right to say that our medical students are less and less interested in becoming family doctors. They don't look on it as an easy job. They don't look at it as a role that is well supported in the current context. And the conditions of work for family doctors are pretty rough right now in most parts of the country. So in order to get to a place where more medical students will train in family medicine, and then to your point, where those who train will decide to go into comprehensive general practice, we're going to have to change those conditions of work.
And Dr. Philpott, when you mentioned the conditions of work, so I can imagine several things. I know many family doctors have to also be landlords and business people, which is probably not the skill set that most doctors have. Some do, but most, like me, don't. So I can imagine that. I can also imagine there's the issue as we have a different population coming through medicine, including both men and women that are taking maternity leaves, parental leaves. You need proper coverage. So there's all those kinds of conditions of work thing. But I also wonder, as an old guy that did a rotating internship, we were qualified, in quotes, to be family doctors at the end of that rotation, of that year internship. And we did appendectomies and delivered babies and put in chest tubes and did all these kinds of interesting things. And do you think there's an issue in family medicine that family docs are not being empowered or equipped to do some of the fun stuff so that they have their procedural toolkit that they can do without consulting a specialist?
I think that's a fantastic question. And I do think that one of the things we will need to talk about in this effort to expand comprehensive primary care is the scope of work of family doctors. And you're quite right that in some ways it's shrunk, in part due to public expectations of sort of being referred for everything. And, that makes the work somewhat less satisfying. It also is because the family doctors haven't got the support to do everything that they need to do. So they're doing jobs that, they could potentially delegate to a nurse practitioner or a nurse or a social worker or a dietitian. And the more that they can delegate to the team, the more they can expand their scope of work, stretch that scope, so that they are doing more procedures in the office, that they are, involved in many ways in hospitalist care and many other parts of the scope of what family doctors can do.
You talk in your book about providing a home for primary care. And I kind of like that because in my home, I can find all the things that I need in one place. It's like a holistic environment that has my music, my family, my food, my bed. Can you tell us more about your vision for these kind of primary care homes that we're all going to be kind of welcome to?
Yes, in fact, I like the way that you've described that. And, one of the things that I've done in the book and in conversations about this that seems to catch on to people to believe that it's possible is I've described the way that, for 150 years in this country, we have made sure through legislation and practice that every child would be assigned to a public school in their neighborhood. And when you move around the country, you never need to worry about whether your child will be able to get an education because it's automatic. We never did that with primary care. But if you can imagine, and I think you can partly because of where you're from, that you can imagine what it would be like if when you move to a community, you are naturally assigned to a health home in your neighborhood. And that health home is not just the place where the family doctor is practicing, but where the family doctor has that interdisciplinary team where they've got the administrators supporting them and where they've got other health professionals. And even in many cases, having specialists who will come into primary care and be able to complement the what's offered there.
I mean, I think on that point, I think it's important to, obviously I'm from the UK and I moved to Canada by choice as an economic choice to kind of benefit Canadian science and also to benefit my own career. It was an expectation that I'd have primary care and school places for my children when I moved here. And it would have influenced my decision strongly to move to Kingston or to move to Ontario had I thought that wasn't the case. So I think there are actually secondary problems with not having these provisions in place. And I imagine as it's kind of the more it erodes, right?
Exactly. And that's, I guess, both a bad and a good thing. The good thing is that it's not just medical people that want to solve this problem. It's municipalities, it's business people who recognize that you're right. Our communities aren't attractive if people say, I'm not going to move there if I can't get access to a family doctor. And so that means that we have a whole lot of people rooting for us in this new project that I'm about to undertake to be able to say, we have to solve this. Kingston actually has been a great place of innovation where we're starting to map out what it will look like to be able to have that geographic model of access to a health home. And hopefully in the fairly near future, we'll get to a place where everyone in Kingston will be attached to a health home in their community.
That'd be fantastic.
Yeah, and I think it is interesting because I think we bought into our own rhetoric in Canada about the excellence of our system, and it's really sort of fraying in the last while. And as an example, Canada's acquired 10 million more people in the last decade or so, but we haven't built the houses, the infrastructure, and the healthcare services so that someone like Dr. Highmarch or the many people that are less privileged that come here can actually realistically expect there's going to be a family doctor. And so it was actually quite interesting. I live in a little place called Treasure Island in Kingston, and when there was word that there were family doctors available, all my neighbors were fleeing downtown to line up in the early morning to try to get access to a family doctor. And you can imagine with Canada's rate of immigration, this is exacerbated because we really haven't expanded our training of doctors in proportion to the expansion of the population, which is kind of a no-brainer contributor to the problem.
Exactly. So I'm happy to say that even at Queen's that we're part of some of the solutions to that we are trying to train more family doctors. And yeah, you're aware of some of the innovations that we've practiced around that in terms of an entire campus now of our medical school that's focused on training family doctors. But, people shouldn't have to stand in line in the cold waiting to sign up. It should be automatic that everyone is guaranteed that access. And I hope we can get there soon.
Yeah, I think you describe it as a kind of a Canadian universal healthcare right.
Exactly.
I think it's absolutely appropriate. So you're starting a new job next week. Congratulations on that for a start. And it's obviously a big role, and it's a very complicated role. In order for our audience to kind of really understand what that role might be, would you mind breaking it down as though we were high school students to tell us what you hope to achieve and whether what are the challenges might be and how you think that job's going to go, and do you think you're going to realize your expectation of having everyone have a doctor in Ontario by 2030?
And tell us the name of the job so we know. Oh, yeah. Now you're Dean and CEO. So what are you going to be on Monday morning?
Well, I'm doing a job that no one's ever done before. So it's got its own name. I'm going to be the chair of the Primary Care Action Team in the Government of Ontario, part of the Ontario Public Service. And, the vision is clear as we've laid out, is that we believe, and the government has endorsed this idea, that 100% of the people of Ontario deserve to have a primary care clinician that will take care of them in an ongoing way and provide timely access. So the vision is already established. To your question about what is the job going to look like, my intention is to spend the first 100 days mapping out an implementation plan, and then the next 1,000 days delivering on the implementation. So, there are now approximately 2 million people in Ontario who do not have a family doctor. So we're not going to be able to solve that overnight, but I think we can solve some of it fairly quickly. And there are two key streams. One is that we need to connect with those who already are family doctors or in primary care teams and say, what could we add to your team to be able to help you deliver care more? So that, maybe you're a group of 4 or 5 family doctors. If you had a nurse practitioner or a physician assistant working with you, or a social worker or a dietitian, would that free you up to potentially either take on more patients or be available longer hours, or in some way be able to provide better access? So add supports to those who are currently in practice.
So you're basically giving these teams a magic wand and saying, if you could wave that wand, what is
exactly.
it? What happens?
Imagine. And then the second big stream is to say there are whole communities where there are, 70,000, 80,000, 100,000 people who don't have access to primary care. We're not going to be able to solve that by, adding a few extra health professionals. We're going to need to add net new primary care teams. Hopefully these will also be teaching sites where we can train more more family doctors. So adding entirely new capacity, as we've done here in Kingston with the Midtown Kingston Health Home, to say, let's actually build a team. They can care for 10 or 20,000 people, depending on the size of the team. And as we map that out over about a 3-year time frame for implementation, we'll hopefully get to the point that we will know that 2 million more people will have primary care, and we will actually have a system in place.
And once you get that fixed, Jane, I encourage you to do that for us specialists, as we specialists as well, because when I go to clinic this afternoon here at Queen's, I will be all by myself. Like, there is no nurse practitioner helping me. And so I think it is interesting. I think it's the old walk a mile in another woman's shoes. You need to consider how people live. And I think the lack of the broad team is a common problem in our Canadian system. In the American system, where if it makes dollars, it makes sense. You get the practitioners working side by side with you to make sure your clinic is efficient. In Canada, it's a fairly bare bones operation, with notable exceptions in certain areas, like cancer care is better funded. But yeah, so I think you're on the right track, and it needs to be expanded to others once you get family medicine fixed.
Okay.
So make a note of that.
Well, actually, on the back of that comment, one of the things that occurred to me, and we discussed it briefly yesterday, is that if you fix primary care, you're going to move on a bottleneck in the healthcare process. Do you just shift that bottleneck up into specialist care, or do you think it dissipates and the bottleneck really is just here?
Yeah, I really think that as we start to solve some of the irritants in primary care, it will have a knock-on effect across the rest of the health system. And, I think, to go back to the science of it, the reality is we haven't followed the science in Canada, because the science has been known for decades that countries or regions who have built a strong system, an intentionally designed system of primary care, get better health outcomes at a more affordable cost, and they provide better access and better equity. We never did that in Canada. So I think as we start to do that, there will be knock-on ripple effects to the rest of the system.
So knowing that there's a shortage of family doctors, and your plan is to try to repopulate family medicine with practitioners that are well supported in Ontario, what advice would you give to a prospective family physician, a medical student considering a career in that profession?
Well, the first thing I would say is that being a family doctor is an incredible privilege. I mean, you probably would say the same thing about being a cardiologist, but, I've been a family doctor now for almost 40 years. I was in practice for about 30 of those years, and it's just such a privilege to be part of the lives of thousands of people that you get to know over time. You get to know them and their families and their medical history. So please don't take it away from your options that you're considering. And, I would say to those learners as well, is that as we launch this primary care action team, one of my key priorities will be listening to learners and to be saying to them, what would it take for you to consider choosing family medicine and for you to consider practicing comprehensive general practice? I need to make sure that we build that into our system design because we need to attract those young people to come.
I certainly think any right-minded specialist would agree. I mean, we need family doctors. And getting back to Charlie's questions about moving bottlenecks forward, I agree that when a patient has a engaged family physician in their life, managing them as a specialist becomes much, much easier. Fewer visits are needed, plans are implemented, unnecessary procedures are avoided, all that type of stuff. So I would encourage young people as well that are thinking of professions that family medicine would be a great option. And I would imagine the job market is going to be, the sky is going to be the limit in Ontario as we begin to try to rebuild the system.
Exactly. And I love the way that you describe that. It works better for everybody if you've got that champion in your life who's your healthcare champion. And imagine if that's even a team of champions that are going to help you navigate the system. So when you as a consultant say, I'd like you to follow up with, ABCD, to the person that doesn't have a primary care provider in their life, they can't do that themselves.
So Jane, on our show, we like to talk to our guests about the bumps in the road that happen through science, because of course we all like to talk about the good things that have happened and our successes, but maybe you'd like to articulate a little bit about a bump in the road that happened while you were Dean of QHS.
Yes, I mean, it's been an amazing experience to be dean here at Queen's, but I think it's coincided with a time where there have been significant challenges. I mean, starting with the COVID pandemic, of course, which we all experienced, but maybe a more specific example is that, the post-secondary sector across the country is really struggling right now in Canada for a whole bunch of reasons. And I don't think it's probably any secret to your listeners that there have been fiscal challenges in universities, and Queen's has not been free of those. It's really hard to run a strong research-based, science-based institution without the kind of support that's necessary. And that there are multiple reasons why universities have not had the support that they require, both from multiple levels of government, but also, due to the impacts of frozen tuition rates, for example, and rising costs of all of the things that it takes to run a university. So we've had to do some hard work, but we had an incredible team working together to say, how can we run the most efficient Faculty of Health Sciences as possible and still make sure that we make those investments in research, which are so important, because that is part of our responsibility as an academic institution. It's not, the teaching is absolutely essential. We give students an incredible experience here at Queen's, but we also want to be a serious biomedical research institution, and that requires some really strong fiscal support. And so I would say there have been some bumps in terms of trying to make that happen. I don't think we're out of the woods yet, but I think that the voice of health sciences is being heard.
Yeah, I think it is interesting, because I think there's a sort of populist belief that tuition should be kept affordable, and it's hard to argue against that. But the reality is, we are currently about 20% underfunded compared to where we were in 2019 because of inflation combined with tuition freezes. And it's at some level, the product is, I think, sort of staggering a bit, and the quality is a bit eroded, not just in medicine, but just in general. And then the lack of international students, which we were sort of using as a funding bridge, is another factor. So hopefully the powers that be will recognize that having sort of an economy based on academic excellence, innovation, and discovery is a nice adjunct to manufacturing and raw materials. And I think Canada would do well. But I'm not sure who's on the other end of this microphone, but maybe when in your new job in government, after you finish family medicine and then fix specialty medicine, you can just walk down the hall and mention that we could use a tuition raise. Okay. On to a more positive note. So what in your deanery or CEO-ory, your leadership roles here at Queen's, what are you most proud of?
Oh my gosh, so many things I'm proud of. It's been an incredible time over the last 4.5 years here, and obviously because of fantastic teamwork. I could cite a few examples. One, as I sort of hinted at earlier, is this innovation that really came from one of your colleagues, Dr. Tony Sanfilippo, who stepped down as the Associate Dean of our MD program and had brought to me this idea about, what if we were to actually train a group of medical students who want to become family doctors and specifically design a program for them where they could stream directly into a family medicine residency. And so that idea happened at the time that we managed to get more seats in medical school, and we had the opportunity to grow our partnership with Lakeridge Health, which is a hospital system to our west. And we launched this first of its kind satellite medical school that is connected to our core MD program here, but it is specifically for training family doctors. It's going to change some of the face of medical education in the future, and it's being watched very closely. So I'm really proud that came together.
That is a big accomplishment. I'm glad you mentioned Dr. Sanfilippo. He's going to be on the podcast coming up because he also has a book.
He does, yeah.
Not yet best-selling, but we'll keep our fingers crossed, called The Doctors We Need. Yes. So yes, we'll have the whole healthcare system fixed between Tony and Dr. Philpott.
Yeah, absolutely. So your book demonstrates nicely how your personal life and the experiences have actually led you to this point and qualified you to be an excellent dean of Queen's University at QHS. What lessons have you learned from this role that you'll take into your next role?
Oh, that is a great question. So, the next role really is interesting because it's, being embedded in government, but to be able to deliver something that's going to have a health system impact. What I have learned over my time in government and even this current role is that not a lot of people that are in those decision-making, policy-making roles really understand the front lines of healthcare, nor do they understand what it takes to make a health professional.
Of course, you were the first health minister of the Canadian government who was medically trained.
Exactly. And so it really changed the way that I was able to do that job because I understood the concepts that we were trying to solve. But the reality is, for a variety of reasons, not very many doctors or nurses or others end up as ministers or bureaucrats. And so the things that I have learned here at Queen's University about what it takes to train doctors and what it takes to train nurses and nurse practitioners is invaluable information that I'm going to be able to take to my new role to say that if we're going to fix this, we're going to need people and we're going to need to support universities in order to train properly, that it takes a whole range of investments to be able to make sure that we'll have the family doctors that we need and the primary care nurse practitioners we need. And having had that inside knowledge and relationships, of course, I think will really set me on my way.
Sometimes I wonder, though, whether it's the lack of knowledge or if it's willful ignorance, because I think the problem is governments can actually see us and they see us as a cost center. They see the cost of training, say, twice as many doctors or the cost of having twice as many hospital beds. So I'll use hospital beds as an example. Relative to other developed countries, we don't have an excess of hospital beds. We're on the lower end. And every year in Canada, when influenza season would come, before we even envisioned COVID, we would be absolutely backed up out the door. But the problem is the government can see the cost of building more hospitals and they choke on that. I think they often, they are building some, but that's hard for them. And I think likewise, they see the cost of training doctors and nurse practitioners who then go out and spend even more money by building the OHIP system. And I do worry. So, I think it is important to understand, and you will bring that understanding to the job, no doubt. But I also wonder if the people you're working with secretly know it. But also, the billions begin to add up. And although they might like a better healthcare system, the question is, can they afford a better healthcare system? And in the States, $1 in every $3 is spent on healthcare, for example.
It's absolutely a big budget item for any government. I'm happy that in the case of my current job that I believe that the government is listening to the fact that it's going to take some investments up front, but that actually doing better often costs less, or it certainly doesn't cost more. And listening to those frontline healthcare professionals, listening to the educators, I think that we are going to find that actually delivering better healthcare and a more efficient system, Canada can potentially not spend any more, but actually deliver better health outcomes.
So obviously, I think personally, you've made a good job of being dean. I've enjoyed interacting with you in the time. We're going to get a new dean. What advice do you have for the next dean that will help them in their role in the coming 5 years or so?
That's such a great question. I think I'm going to make sure that they recognize the incredible team that already exists here, and to get out and listen to people, to visit the research centers and visit the classrooms, and start to see the spaces and the people that are behind them, to continue the great work that is already happening, and to build strong relationships with the entire spectrum of health sciences. We're really lucky here because we do have biomedical scientists like yourself. We've got so many incredible clinicians and clinician scientists here. We've got nurses. We've got our rehabilitation therapy experts. We've got our public health sciences. And I think the next dean needs to understand that incredible breadth. And we like to say that what we do well here at Queen's Health Sciences is collaborate well. In fact, we talk about radical collaboration as one of our strengths. And so I hope the next dean will take that and run with it.
Good. Well, before we wrap up the podcast, we'd like to take a moment to thank you for being our dean and for being the CEO of our big practice plan, which is called SEAMO, which is instrumental to having excellent healthcare in Southeastern Ontario. We wouldn't be where we are if we didn't have SEAMO. And then you've been very ardent about supporting education and clinical care and a strong ally for research at Queen's. So you certainly left your impact here, and I'm glad we got to see you. Your last day is Friday, and then your new job, your first day is Monday. So I'll turn it over to Charlie for some closing questions.
But before we let you go, we do a bit on the podcast where we ask you some slightly sillier questions. This is us trying to get to know you, but also our audience trying to get to know you. So buckle up. What's your favorite food, and can you cook it?
Oh, man, I have so many favorite foods, but I would say that I'm a seafood fan, and particularly shrimp. I just love, and I can cook it 100 ways.
Do you like it with spices?
A little bit of spice, for sure, yeah.
And what music do you like, and what gets you motivated?
You know what? I have silly music tastes. I am actually a pop fan,
Did you have Taylor Swift tickets?
I didn't. I tried really hard, but I did not get Taylor Swift.
You had a whole team of people in QHS ringing up.
I have 4 young adult children, and I like to try to keep up with some of the music that they're listening to. And on a very fun evening, we'll actually get the music going and have a little dance party in the kitchen, and that's the kind of music that makes me happy.
Excellent. Okay, so the next question is something that we'll edit and change post-edit, if that's okay, Charles. What's your favourite research institute at Queen's?
There's only one right answer.
I know what the right answer is on that one. So
no comment.
Yeah, I'm going to pass because I could get in big trouble.
Yeah, I thought you might say that.
Yeah, I thought so.
So if you were on Who Wants to Be a Millionaire, who would be the friend that you would phone for help?
Oh my gosh. Wow. What a tough question that is. Who would be?
You're going to alienate all the people.
Yeah, exactly. I'm going to pick my husband because
that's a great answer.
Because he's incredibly intelligent and well-read, and he probably knows the answer.
Okay. Well, I can't believe you didn't say Time was your favorite research institute when you gave that self-serving answer.
Like I say, we're going to edit that.
We'll edit it all later.
So lastly, and this is the most important question that we ask any of our guests, if you were a cartoon character, which one would you be and why?
Oh my gosh. What a tough question. I am going to pick Winnie the Pooh because I kind of just feel like Winnie the Pooh is a cuddly character who means well and kind of stumbles his way through life and gets stuck in awkward positions periodically, but is really earnest and wants to be a good friend. So I'll go with him.
Well, we'll pull the honeypot off your head and we'll accept that answer.
Dr. Philpott, on behalf of Dr. Archer and myself, I'd like to thank you for taking time to talk to us and our audience today about the importance of primary care to Canadians and your mission to ensure that everybody has a doctor. I'd like to remind our listeners that Dr. Philpott also is the author of a best-selling book entitled Health for All, where she articulates her desire for a Canadian universal right to healthcare within the context of primary care systems. You can buy this book in audio or in analog format from all good retailers. Lastly, I'd like to thank you for taking time to get to know Dr. Philpott with us, our outgoing Dean and the Ontario's new chair and lead of Ontario's new primary care action team, which aims to link every person with a doctor by 2030. If you enjoyed this episode and would like to know more about research at Queen's University or to share this podcast, you can search for Time to Talk Science and Medicine wherever you normally look for your podcasts. Thank you.
Thanks for having me.